Well, good morning.
Good morning.
Thank you very much for having me here today. I'm really excited to be here. You're going to have legislators here at lunch. Hopefully the governor will make it here this afternoon. Take advantage of those opportunities. Take advantage of them. The legislators listen to physicians, to providers, to people in your positions, and the magic number is 5. If you talk to lobbyists, if you talk to legislators, usually if they hear from 5 or more people, that is oftentimes enough to swing their opinion on an issue, or to say, if the phone rings 5 times, I've heard from 5 different people in my district. It makes a difference, and when they're here, use that opportunity. Please, please, please. My talk will not be along these lines, but one of the priorities of my time as health commissioner is to change the way that we engage and that we talk to legislators on policy issues. One of the problems, I think, and it's weird to say it's a problem, but we've thought for decades that the compassionate argument is going to win the day. It's simply saying, I think we need to do this because it's the right thing to do is going to win the day. Well, everyone who's coming to the table thinks that their way is the right thing to do. People are dying because we don't have good roads and people are getting in accidents. People are dying because they're starving because mom and dad can't get a job. There are all sorts of competing interests at the State House, within the legislature, and you've got to change the way that you talk about things to more of a, I call it the love language of legislators is economic impact, it's jobs, it's workforce development. And I had a great discussion with David Nugent, who's going to be speaking with you all on a panel this afternoon about this, but we've really got to change the way that we talk to legislators if we want to be successful on whichever issue it is. How is it affecting business? How is it affecting jobs? How is it affecting workforce development? And I think we'll be more successful moving forward. So the Indiana State Department of Health. Our mission is to promote and provide essential public health services, and our vision is a healthier and safer Indiana. Now, there are over 800 employees that work under the State Department of Health. And one of the things that's unusual that I'd like to talk about is the structure of the ISDH. We have 4 different divisions. We have a tobacco cessation division. We have commissions. We have health and human services. We have a regulatory commission, and we have an infectious disease public health preparedness lab division. We serve at the pleasure of the governor. We are a function of the executive branch. And why is that important for you all to know? It's important for you all to know because our priorities are going to be the priorities of the executive branch. When you speak to legislators, you can speak to them in terms of their party and their priorities. But within our department, we're going to reflect the priorities of the executive branch. And fortunately for me, I've got a great boss, Governor Pence, who again, I hope you hear from later today. And we're in line with where the top priorities should be. But you want to know what their priorities are and try to frame what you want within their priorities. So what are the governor's priorities? What are the executive branch's priorities? Well, if you heard the State of the State address last week, he emphasized that infant mortality was his top public health priority, and I'm proud, so proud of him for stepping forward, committing not only his voice to that, but he's committed money within the budget to furthering the infant mortality cause. And his wife, Mrs. Pence, helped me unveil the infant mortality initiative, our Labor of Love campaign, just last week. Public health preparedness, obviously. With Ebola, with the flu, all that's going on, there's going to be a lot of talk about that coming up. And then HIP 2.0, trying to get people covered through that program. So try to think of your ask in terms of how can we fit it into one of those priorities when you're speaking to the executive branch, and you will be a lot more successful. Our top health priority is number 1, a reduction in infant mortality rates in Indiana. Number 2, a reduction in our adult obesity rates. And number 3, a reduction in our adult smoking rates. If you all saw America's Health rankings that came out at the end of 2014, unfortunately, we're still ranked 41st in health status amongst the other states. And these 3 factors are major contributors to the reason why we're still in the bottom 10 states. Starting off with smoking, we're 12th highest for adult current smoking by state. The good news is that we're coming down. Slowly, but we're coming down. We were at 25.6 in 2011, 24% in 2012. 2013 numbers were at 29%. So we are coming down, but we're still lagging severely behind the rest of the country on our smoking rates. Now, you heard me talk about economic impact. Every pack of cigarettes in Indiana costs $15.90 in healthcare costs, lost productivity, and premature death. Or another way of looking at this, it's $550 per Hoosier household per year is the cost of tobacco in Indiana. We have certain populations that are particularly affected by smoking in Indiana, and we're going to concentrate on those populations this year in focused efforts. Mental illness, 39%. People who are below poverty, 34%. People with less than a high school education smoke at a 37% rate. And people who make $15,000 or less, 38%. Smoking, we are abysmal in terms of smoking during pregnancy. And if you look at our rates versus the rest of the country, Indiana, 16.5% of our pregnant moms smoke overall, whereas in the total U.S., 8.7% of pregnant moms smoke. So we are almost double the United States rate in terms of mom smoking. And it's all over the county, all over the state. This is just a map of Indiana overall. We've got counties that range up to 33.9% smoking rates during pregnancy. And another number I want to draw particular attention to, particularly as many of you represent rural health districts with more Medicaid people, our Medicaid population, almost 30% of our Medicaid moms smoke while they're pregnant. We've got to move that number. So what are we doing as a state to help move that number? Well, we've got the 1-800-QUIT-NOW tobacco quit line, which I'm very proud of, and I want all of you all to remember that number when you leave here. It's easy, 1-800-QUIT-NOW. You can refer your patients, your providers, your families, your friends to that number. And as part of that, we've also partnered with the Baby and Me tobacco-free programs. Now, if you look at our quit line call volume, we served over 10,000 people just in 2014 alone. And for all of you in the audience, you can be a part of the Quit Now Preferred Network. It's just that instead of reaching out to the individual, it's our effort to reach out to employers, to providers, to help make sure you're getting the information you need to set up quit line referrals. Refer those ready to 1-800-QUIT-NOW. We have over 6,000 people in our preferred network, and you can go to quitnowindiana.com for more information. But we're having all sorts of success. We've got a group of vascular surgeons at Methodist Hospital down the street who are really, who decided, hey, we're all going to work together, we're going to increase our quit line referrals, and we're working with them to get pre-populated fax referral sheets. But one of the things I'd really like our providers to do is to try to incorporate the quit line into their electronic medical records to make that referral happen more automatically. The Baby and Me tobacco-free program, we had 8 pilot sites, over 400 participants, and I'm impressed to say we had a quit rate of 72% with the Baby and Me tobacco-free program. That is very impressive, and we want to keep expanding it if we can. What does it include? It includes 4 prenatal visits, monthly postpartum visits, but the key to it is it provides a $25 voucher for diapers for every time the mother comes in and she tests negative on the carbon monoxide test. So they're being tested for tobacco usage, and if they test negative, they get a $25 voucher for diapers. That, along with the prenatal visits, the postpartum sessions, the counseling, has proven a powerful, powerful combination for helping moms quit smoking. So if you can tout 2 things when you're talking to legislators, 1-800-QUIT-NOW, Baby and Me tobacco-free, we would like to expand those. But unfortunately, as Beth and I have discussed many times, we're fighting against, for every dollar that we spend in cessation efforts, there's $100 being spent in advertising against us. It's an uphill battle, and we need all of you in our Army to help fight it and to bring it to the attention of our legislators and to show that the economic impact of not treating the problem is worse than the economic impact of putting a few tobacco employees out of work, which I'd love to do. We're being recorded. I didn't say that. Prevalence of adult obesity by state. We're ranked 9th highest in the country for obesity, again in the bottom 10 states in the union. Over 2/3 of our adults are overweight or obese. To put this in perspective, that's equivalent to the entire population of Iowa. We have enough obese people to fill the entire state of Iowa. Our obesity rates are much higher in minority populations and in rural areas. And if we have some time at the end, I'll show you some of our data from rural areas. Prevalence by education. This is an interesting graph. You see that high school GED, 33%, some college, 33.6%. I don't know if that's indicative of the freshman 15 that they talk about or just what, but if you get just enough college, then you actually need more. But college grads, they have a much lower rate of obesity. So there is an educational component to doing the right thing. And perhaps there may also be an economic opportunity component that these college grads have. They can afford more food, they can live in better neighborhoods, they don't have to be in a food desert. All things to consider. And if you look at by race and ethnicity, you'll see that while Indiana rates at 31.8% for obesity, our African American rates are 41.7%, much higher. Our Hispanic rates are 34.9%, and the white rates are 30.6%. So you see, and you'll hear me say this many times over, we certainly have an obesity problem in Indiana, but on a lot of our health indicators, we think we have a health indicator problem, but what we really have is a health disparity problem. Because if we could fix the disparities, we would bring down our rates significantly. And this is just prevalence of self-reported obesity amongst Indiana adults by county. So the white is good and the darker red is bad. And you'll see we've only got 2 counties in the white, and they're still not where we want to be. The white is 22.1%, so still over 20% of the population is obese, and everywhere else in the state is worse. So what are the costs to Indiana? What's the economic impact of obesity? $3.5 billion in obesity-related medical costs. In Indiana, 36.9% of our obesity-related costs are financed by Medicaid and Medicare. So when you're talking to your legislators, the programs that they're funding, that they're paying for, that they're trying to find ways to fit within their budget, we could bring down those costs if we treat these problems. There are studies showing obese children miss more school than their normal weight peers, and obese adults experience more absenteeism and presenteeism than their normal weight peers, which is why you're seeing companies and organizations get together and talk about, hey, what can we do within the company, even if the legislators aren't taking care of this problem, even if the government's not taking care of this problem, our bottom line is being affected by people who are smoking and people who are obese. Yearly health care costs for obese individuals are higher by $1,400 per year. Again, going back, when you look at Medicaid costs, the Medicare costs, the insurance company costs, it's definitely something from a workforce and business point of view that we have to address. So what are contributing factors? You all know this. We're eating more, we're moving less. It's calories in, calories out. But drilling down a little bit deeper, there's easy access to fast food. There's fast, less nutritious food on every corner, and we've got a lot of food deserts within our state. So there's an inability to access healthy food by the average Hoosier. Less opportunity to engage in physical activity, and there's all sorts of initiatives going on around our state to help people be more active, and then increased screen time, which is something we all fight with. I fight with my kids every night about turning off the TV and going outside and playing, but it's something we've got to work with our population, our Hoosiers throughout the state to help decrease the screen time and increase the physical activity. So we need providers, and there are a lot of providers in this room to talk to their patients about this. I know the healthcare visits are packed full of things that you need to get through, but we've got to continue to talk to them about their weight. Because when they come in to see their provider, when they come into the doctor's office, they're coming in, and that's an opportunity. It's an opportunity for you to engage them about weight and to put it in the context of their health. And it may be an opportunity one that changes their life. And it doesn't matter if you talk to them about it the last 10 times they came in, maybe this is the time they're ready for change. So remember to always, always, always discuss with them, what are you doing to be more active? What are you doing to eat healthier foods? And hopefully, if there is a barrier, you can connect them to services. Community level changes, we need access to physical activity, and that covers the spectrum from YMCAs to better streets, more sidewalks, all sorts of things that we can do, and I'm sure you all can think of, to help allow people to be more active and access to healthy food. Workplace solutions. Again, as I mentioned, we're seeing a multitude of wellness initiatives throughout companies because they're realizing we simply can't wait for the government to do it for us. We've got to do it within our company and make sure that our employees are healthy. And then in schools, we want to work with them to provide healthy food and to increase physical activity. So ISDH initiatives, and I'm just going to gloss over these, but if you have any questions, our nutrition and physical activity people are here, ARP's here, they'll be happy to talk to you about any of these individual initiatives. But Farm to School, that's an initiative where local farmers can provide fresh produce to schools, more professional development within schools, safe routes to schools so children can walk to school, early childhood centers so they're not sitting at home in front of that screen, healthy work sites, as I mentioned, communities. There are all sorts of different initiatives going on within communities to help decrease obesity. And then healthcare, primary care learning collaborative, just amazed about that. Many of you all are familiar with that. You're involved with the primary care collaboratives throughout the state. They are doing some amazing things in terms of moving the needle, particularly on obesity and physical activity and the sequela of obesity and physical activity. Infant mortality. Again, governor's top public health priority. Big campaign we just launched. We were ranked 42nd in 2011 at a rate of 7.7 deaths per 1,000 babies born. 39th in 2012 at 6.7%. And so a little tick down, but unfortunately, that doesn't look like it's a trend. The preliminary data from 2013 show we're going back up again to 7.15, at least preliminarily. So we've still got a lot of work to do. What does this mean in real numbers? Over 600 babies die every year in Indiana. And we got some counties in our state with rates that are worse than third world countries in terms of obesity. Again, it's the governor's top public health priority. And what's the economic impact of that? I was on Inside Indiana Business with Barbara Lewis, and she asked me that question. Well, number one, you've got 600 babies who are dying every year. That multiplies. That's a tremendous effect on your workforce. We're losing talent. And I hate to put it in so blunt terms, but quite frankly, we're losing our best and brightest before they even make it to their first birthday. The other impact is not just infant mortality, but infant morbidity. If baby's in the ICU for 3 months, that's 3 months mom can't work. That's another person you're losing from the workforce. There's other family members who have to be available to take care of that child. So there is a tremendous economic impact in addition to the impact on emotions and on our hearts of making sure that babies aren't dying in our state. What are the factors that contribute to infant mortality? Well, smoking is a factor. And what we found, interestingly enough, when we looked at the data, is that smoking is not a primary factor. We can't show based on our data, which shocked me, to be honest with you, but it's the truth, that smoking was directly related to infant mortality, but it's directly related to birth weight and to morbidity, and it's an amplifier of all other factors. So if you're poor and you smoke, through the roof. If you're undereducated and you smoke, through the roof. So smoking is an amplifier of all other factors. We went through the numbers. 30% of our Medicaid moms smoke, 12th highest smoking rate in the U.S. Obesity, which is the number 2 priority, is again an amplifier or a cause of infant mortality. If you're obese, you have a 25% chance of having a premature baby. If you're morbidly obese, it goes up to a third of a chance of having a premature baby. Again, tremendous impact on infant mortality and morbidity. If you look at our percent smoked during pregnancy, the top blue line is Indiana's rate, the bottom line is the United States, and then the line at the bottom is the Healthy People 2020 goal. For the life of me, I can't figure out why that still hovers above 0, but why our goal isn't 0. But you see that our percent smoked during pregnancy, as I mentioned, is twice the rest of the United States. Other factors contributing to infant mortality in Indiana, limited prenatal care. Only 68.1% of pregnant mothers, or about 2/3 in Indiana, receive prenatal care in the first trimester. And that is what we're finding from the data is the strongest risk factor for infant mortality. The thing that we can most change is getting moms into prenatal care early and then helping them have regular prenatal care. I was asked by Barbara Lewis, what's the one thing you can do? It's getting moms into early and regular prenatal care. Because if they're in talking with someone, they're in having these visits, they're going to talk about staying away from alcohol, tobacco, drugs. They're going to talk about making sure you have a healthy environment at home. They're going to talk about proper eating and proper nutrition. Just get them into that provider and other good things will happen. Unsafe sleep. This is one of the biggest tragedies when you dig into the infant mortality numbers. 15.8% of our deaths in Indiana in 2012 were due to unsafe sleep. What do I mean by that? That means not putting your baby on their back in a crib. It means co-sleeping. I mean, there's nothing than seeing a parent who accidentally rolled over on their baby and caused a death from co-sleeping. It's something that we definitely need to change. We've got the Cribs for Kids program in Indiana, but talk to your parents, talk to your potential parents, your pregnant mothers, about cribs and about the ability for that baby to have a safe place to sleep, because these are 100% preventable. We can't prevent all infant mortality, unfortunately, but we can stop accidental deaths. We can help babies sleep safer. Elective delivery before 39 weeks gestation. You know that as of July last year, we changed the Indiana Medicaid rules to stop payment for elective deliveries before 39 weeks. The governor was very proud of that, and we're hoping to see some dividends from that. It's also an ACOG recommendation. And then limited breastfeeding. I was taken to task on a different interview last week with Amos Brown about breastfeeding, and it's something that it's cultural, and it's something that we need to get more comfortable about talking with our patients about. I know there's people on both sides of the argument, and they can be very, very persuasive in presenting their case. But we do know that breastfeeding is a factor that contributes to morbidity and mortality, and it's something that we need to get more comfortable having a conversation about. Delivering at risk-appropriate facilities, that's another big initiative, perinatal regionalization, making sure babies are born at the right place, at the right time for them. And that works both ways. We can't send every kid down to Riley. We don't have the resources to do that. So we want to make sure that within different areas throughout the state, we've identified a network so the baby, if it's appropriate, they can be born near home. And if not, then we've identified it earlier, and mom and baby are going to a risk-appropriate facility. So what's our plan to promote good health in women and infants? Well, again, statewide infant mortality campaign to raise awareness about the problem and resources. The website is www.laboroflove.in.gov if you want more information. And make it even more simple for you. If you have a mom who's thinking about becoming pregnant, or a woman who's thinking about becoming pregnant, who already is pregnant, who wants more resources, all they have to do is pick up the phone and dial 211. And they will be connected to someone who can help them find the resources they need, whether it's insurance coverage, whether it's education. No matter what it is, they will get connected to the resources they need and have their questions answered. The majority of the questions that have come across that line so far are about WIC, the WIC program, but covers the gamut, and it's easy to remember. 211, recommend them to that site. And it doesn't have to be someone who's poor. I mean, anyone who's pregnant, any mom that you have, if we get that word out, if we get everyone across the state knowing, aware of the fact, and acknowledging that 211 is where you call when you're pregnant, it's going to help bring up the health across the state. Statewide public health nurse visitation program. This is a collaboration with the Nurse Family Partnership and Goodwill. We were really excited about this program. We've seen tremendous results in Marion County where that first has been occurring, and we're hoping to roll it out into other at-risk areas. But this is getting at that prenatal care and intervening early aspect of infant mortality. This is a program where nurses go out and have several visits with first-time moms. And they found that even though the program is designed for first-time moms, they found that sibling health comes up, the health of everyone in the family comes up, simply because that nurse is interacting with that family and helping to make sure they're doing the right things to raise a healthy baby. Our 39-week initiative, and I'm drilling a little bit into this because usually I get lots of questions about this. Providers are sometimes frustrated about the 39-week initiative. In case studies on early elective deliveries, they found that they were linked to neonatal morbidities with no benefit to the mother or the infant. What morbidities are we talking about? Increased adverse outcomes, death, NICU admissions, respiratory outcomes, extended length of stay in the hospital. ACOG has promoted a clinical guideline discouraging elective deliveries prior to 39 weeks without a medical or obstetric need. So again, that last little bit is the thing that I also like to bring up when I'm talking to providers, without medical or obstetric need. So we're not saying we're not going to pay if you have a baby before 39 weeks if there's a medical indication. We're just saying that you need to document that medical indication, and we're not trying to get in between providers and their patients. But we do know that there's evidence out there that suggests that electively having a baby before 39 weeks increases bad outcomes. When we compare our data to other states in Region 5, Indiana, Ohio, Michigan, Illinois, Wisconsin, and Minnesota, our birth certificate data, we found that our elective delivery rates were much higher than other states in Region 5, so that's why we pushed that initiative. We have to acknowledge the March of Dimes, FSSA, and the Indiana Hospital Association for helping us with this initiative. It really took that partnership to bring it together. Spencer's in the back of the room, he'll tell you, you start talking about taking money out of people's pockets, the arrows start coming out. But if we can all get together and realize that you're going to, again, the economic impact of infant mortality is much more than the economic impact of trying to disincentivize people from improper medical care. And then, again, this policy went into effect in 2014. As far as Safe Sleep, we've worked collaboratively with the Department of Child Services. They've been wonderful regarding Safe Sleep. I'm going to increase parent and caregiver awareness of SIDS as a problem. Our Cribs for Kids program, again, a tremendous, refer your patients and friends and family to that. We want to increase parent and caregiver knowledge of risk reduction methods, again, on your back in a crib, and reinforce the importance of safe sleep messaging within the community. Every single one of you all knows someone, and true confession, I have the same picture too on the Facebook page of dad laying down and baby laying on their chest asleep. Well, it's a cute picture until, unfortunately, again, dad rolls over and baby suffocates, and it only takes literally just a few seconds for that baby to be suffocated. So we've got to get that message out and change and raise cultural awareness of safe sleep practices. These are our safe sleep distribution sites from 2014, and as part of the kit, you get a portable crib, a fitted sheet, a wearable blanket, a pacifier, and education about safe sleep. Going on to breastfeeding, U.S. national rates, exclusive breastfeeding at 16 months, 18.8, ever breastfed 79.2. In Indiana, we're not so bad at exclusive breastfeeding at 6 months once they get engaged, but significantly behind the country in terms of ever breastfed. Why does that matter? Well, breastfeeding to reduce infant mortality, case control study found children who were ever breastfed had lower risk versus never breastfed children for dying in the postnatal period. Longer breastfeeding is associated with longer risk, but I go around and tell people, I'm not trying to convince you to breastfeed your baby till they're 5. Now, there are people out there who will say that you've got to do that. That's not me. What I'm saying, my message is the data suggests that if you breastfeed 1 day in the hospital, it's better and your infant has a better chance of living than if you don't breastfeed at all. If you extend that to 3 days, the whole time you're in the hospital before you go home, it's better than 1 day. If you extend it to a week, so it's important that we have that conversation and tell these moms, we understand there are barriers, cultural barriers, economic barriers, job barriers, and we've got to work to remove those barriers. But we understand there are barriers to breastfeeding. We're going to help you overcome them, but at least while we're in the hospital, let's get it started. Let's get it started, and you're going to increase the chance of your baby making it to the first year. Exclusive breastfeeding reduces infant mortality due to common illnesses such as diarrhea or pneumonia, and that's because mom's immunity is passed along to baby. And then sudden infant death syndrome, case control study determined that breastfeeding reduced the risk of sudden infant death syndrome by 50% for all ages of infancy, an amazing number. And then finally, a meta-analysis found that breastfeeding is protective against SIDS, and the effect is stronger while breastfeeding is exclusive. Breastfeeding State Strategic Plan being developed by National Institute for Children's Health Quality, collaboration between many different groups coming together to try to increase breastfeeding in our state. And we convened an expert panel in November 5th of 2014. Please look to that panel. Please get involved. Again, it's going to take all of us coming together to change the attitude and the culture about breastfeeding. The Indiana Perinatal Quality Improvement Collaborative, established in fall of 2012, with a vision that includes all hospitals have an important role to play in ensuring all babies born in Indiana have the best start in life. All babies in Indiana will be born when the time is right for both the baby and the mother, and they're really pushing our perinatal regionalization initiative. And through a collaborative effort, all women of childbearing age will receive risk-appropriate health care before, during, and after pregnancy. They're doing so much more than that. They're working on so many other issues, such as neonatal abstinence syndrome, so many other things, but really this is what their core is about, and we're really looking to them to help us figure out how to tackle this problem in Indiana. Another thing I'd like to point out when I point out health disparities, infant mortality rates by race in Indiana. You see that our rate is 6.7%, that's the blue line, and the white rate is 5.5. The Healthy People 2020 goal is 6.0. So we are already below the Healthy People 2020 goal for white moms in Indiana. This is one of those areas where I suggest we don't have an infant mortality problem in Indiana. We have a health disparity problem in Indiana. Our black moms, our rate for black infant mortality is 14.5, almost 5 times that for the white moms. If we could bring our black rate even halfway down to our white rate, we would meet the 2020 goals for infant mortality. If Indiana lowered our rate in 2012 to the white infant mortality rate, we would have saved over 90 black infants who died in the year 2012. So where is this occurring? 65% or 95 of the 146 infant deaths in 2012 occurred in just 3 counties, Marion, Lake, and Allen County. So that's where we're going to focus some of our efforts and some of our monies, hopefully towards lowering the infant mortality rate. We had 9 grantees in these 3 counties last year, totaling $1.7 million. And then finish with emerging infectious diseases. MERS, you all heard about that last year. They did a wonderful job with that in Munster. And my term so far since I took over, I call it Flubola. It came in and I was announced at the governor's press conference on Ebola, and it's just drifted right into the flu. And we're up to 85 deaths from the flu so far this year. Some of you may have heard me say we are not taking it seriously enough. It's not just another flu season. People are dying, and everyone plays a part in that. Everyone plays a part in making sure that we stop the flu here. Everyone in here who doesn't have an immunization. There are medical reasons for not having it, but you're potentially bringing the flu, even if you aren't getting it, bringing the virus in to other arenas. Everyone in here who isn't talking to their patients and providers about proper hand washing and proper care to prevent the spread of the flu. And then also as providers, we know that we're not prescribing antivirals enough when people are diagnosed with the flu. And then the big thing that's going to be coming up is antibiotic-resistant organisms. Nationally, CDC listed antibiotic-resistant threats in their 2013 report. More than 2 million infections each year, 23,000 people died as a result of antibiotic-resistant organisms. CRE is popping up on the radar screen, and we're going to be trying to make that make it mandatory that people have to report CRE infections in Indiana. Mortality rate of almost 50%. Terrible. We've got to start putting these things on our radar screens before they become a problem. And it makes me think back to a comment that I often make when I'm trying to convince people about striking when the iron's hot with the legislators and knowing what they're talking about. If I stood in front of this room at this time last year and told you all that my number 1 public health priority was to get $1 million more for Ebola, you all would have laughed me out of the room at the time. It's really about striking, we want to learn to be more proactive and see these threats coming instead of reactive. But you also have to strike while the iron is hot. We're doing a lot on the antibiotic resistance front, and I'll just quickly go through this. If you have more information, please talk to us. But we've got a very robust lab division. And then the Ebola virus disease preparedness, where I'm going to when I leave here is to a district to discuss Ebola preparedness throughout the state. We're doing a lot with that, and I've just been amazed at how the rural community has stepped up in terms of Ebola preparedness to make sure that if it does come to Indiana, we're going to stop it in its tracks. Screening at 5 U.S. airports, direct active monitoring for all Indiana travelers. So we're doing more in Indiana than what the CDC recommends. And again, that's because the governor feels it's important, I feel it's important, that we're doing all we can to prevent Ebola from getting a foothold in Indiana. And you all know about this, and if you have questions, please ask me, because we've talked a ton about Ebola. The flu season, you know that too. We've got 85 deaths. Vaccinations, proper precautions, hand washing, covering your mouth when you cough or sneeze, and talking to your doctor about antivirals if you get the flu. And then you may have heard, it came out last week, that CDC said that the vaccine is only 23% effective against the flu. Well, that's not a reason not to get the flu shot. That means we've got a nasty bug and we need to do all we can to prevent the flu. And all of you in here, we're all smart people, we know math. 23 is still greater than 0. So I'd rather have a 23% chance of stopping the flu than a 0% chance. And I'm going to run through these. This will literally take 1 or 2 minutes, but we've got some interesting health stats again because we've got the Rural Health Association here. Adults with flu shot in the past year, the rural is green on the right, urban is 36.2. Rural areas are lagging behind on the flu shots. And unfortunately, that's where we're seeing a lot of the deaths from the flu, is in rural areas. Mortality rate, all causes, is much higher in our rural areas than in our urban areas. If you pull out Marion County, it's even more so. 848 to 804 in urban areas for mortality rate, all causes. What are those causes? Heart disease, higher in rural areas, and again, all these slides are on the way. Cancer, higher in rural areas than in urban areas. Lung cancer, 60.5 to 56.8 in urban areas. COPD prevalence, much higher in rural areas than in urban areas. Adult current smoking, a little bit better, but still higher in rural areas than urban areas. Female breast cancer is one place where rural areas are doing better than in urban areas. 21.3 mortality rate as compared to 23.2 in urban areas. But females with a mammogram in the past 2 years is lower in the rural areas. So we've got to work on talking to women about getting mammograms. Infant mortality, and this is another interesting slide that shows disparities. You'll see that across the board, the green is rural, that infant mortality rates are higher in our rural areas than they are in our urban areas. But if you are black in rural, your rate is 22.9%. You have almost a quarter of a chance of having your baby die in the first year if you're a minority in a rural area. So remember that. That is a very at-risk population. Prenatal care in the first trimester, lower in rural areas versus urban. Smoking during pregnancy, you can see from the green line, much higher in our rural areas versus our urban areas. Females with a Pap test in the past 3 years, lower in rural areas versus urban areas. Blood stool test in past years, lower in rural areas versus urban areas. Sigmoidoscopy or colonoscopy, lower. And I'm sorry if it seems like I'm beating up on the rural areas, but I want you all to know these numbers, and each of you has a different area of emphasis. So I want you to get the relevant numbers for your area, particularly lower in rural versus urban areas. My father-in-law is a farmer in northeast Indiana, and it took years for me to convince him that he needed to go in and get his colonoscopy. It's just that macho, it's the Indiana machismo, you know. But we've got to convince them of the utility of it and let them know that really it's the right thing to do for their families. And finally, I convinced him because we all sat down and said, hey, we want you to be around for the grandkids. We want you around to see them grow up. Adult obesity, higher in rural versus urban, which leads into diabetes. Always never wear a seatbelt, much lower in rural areas than in urban areas, and you're going to hear information about the trauma, improving our trauma system in Indiana. We have a lot more accidents and a lot more deadly accidents. And a lot more deadly accidents in our rural areas. Number one, because it's hard for them to get to where they need to, but it starts here with a seatbelt. Again, my father-in-law, farmer up in northeast Indiana, never wears a seatbelt. I don't need that thing. We've got to get people thinking about doing the right things. Good health or better health status, lower, good or better health status, lower in rural areas. Asthma prevalence, great thing, it's lower in rural areas than in urban areas, so we're going to finish on a good note here. Ever been told they had depressive order, lower in rural areas versus urban areas. So I think those two things, the lower depressive order, lower asthma, lower breast cancer, leads us to less binge drinking in rural areas. So I wanted to finish on a positive note. And with that, I don't think I have time for questions, but I will be available throughout until about noon for questions. And again, Art, Miranda, anyone here from the ISDH, we're here for you all. We are your State Department of Health. That's why we're here. Don't ever be afraid to call us. Don't ever be concerned or think that's a stupid question or you won't want to talk to me, because that is why I'm here, to help take care of you all, meet your needs, and make sure that you have everything you need so that you can go out and be the soldiers that we need throughout the state of Indiana to make it healthy. Thank you very much.